Welcome to Learning Unit on using digital tools for image analysis in clinical reasoning. Today, we will explore the basic principles of AI image analysis, its clinical benefits, and the critical risks you must evaluate to ensure patient safety. Modern medicine generates more images than any clinician can fully process across radiology, pathology, dermatology, endoscopy, ophthalmology, and other fields. The problem is no longer image acquisition, but interpretation at scale. AI entered the space not because clinicians are failing, but because complexity has outgrown human bandwidth. Today, we'll focus on how AI analyzes images and where its real clinical value and risks lie. The key question is not whether AI works, but when it can be trusted. AI based image analysis tools operate on principles of computer vision and deep learning. Instead of seeing a patient, the AI processes digital arrays of data to map features such as texture, shape, and density against patterns learned from thousands of previous cases. Unlike humans, AI does not understand organs or lesions in the human sense. It detects patterns that correlate with them. Through layered processing, these pixels becomes edges, textures, shapes, and eventually patterns that correlate with pathology. This hierarchical feature extraction is the foundation of modern medical image analysis by AI. But understanding how AI sees is only the part of the story. We also need to understand how it learns. Most medical image analysis relies on convolutional neural networks, which excel at spatial feature detection. More recently, vision transformers have entered the field, enabling global context awareness, important for whole slide pathology or full CT volumes. In practice, many state of the art systems combine both approaches. High quality annotations are expensive and scarce. To address this, modern systems increasingly rely on weak supervision, such as diagnostic reports or self supervised learning, where models learn structure from unlabeled data. Understanding the training paradigm is essential for judging model reliability. Importantly, more accurate models are often less interpretable, creating a trade off between performance and explainability. High accuracy on a training dataset alone has little clinical meaning. Robust AI requires external validation across institutions, scanners, and patients. Dataset shift, changes in protocols, or demographics is one of the most common reasons models fail in real world settings. Successful systems integrate into clinical workflows as triage tools or second readers. The most effective designs keep humans in the loop, allowing clinicians to override, contextualize, and learn from AI outputs rather than passively accepting them. For instance, in cardiology, AI might automatically measure the ejection fraction from an echocardiogram, or in dermatology, it might provide a probability score for malignancy in a skin lesion. As a clinician, you must evaluate the validity and reliability of these outputs. Does the AI's finding align with the clinical context? Remember, AI outputs are probabilistic, not definitive diagnosis, and responsibility for the final diagnosis always remains with the clinician. The primary benefit of AI in clinical image analysis is to support clinicians' diagnostic process and differentials, and this may include increased efficiency, human error reduction, and standardization. Let's start with increased efficiency. This means rapid training of urgent cases, such as detecting a pneumothorax on an X ray. For example, commercial platforms such as Viz AI analyze images, CT scans, or X rays to detect early signs of a stroke or pulmonary embolism. Next, reducing human error means offsetting visual fatigue and common interpretation errors. For example, tools like AI Doc flags acute conditions such as intracranial hemorrhages or lung nodules, acting as a safety net to identify critical findings that might be missed due to human interpretation errors. And lastly, standardization. This means providing objective measurements that reduce variability between different clinicians. For example, tool Path AI analyzes histopathology slides to identify cancer subtypes, a process that reduces inter-observer variability among pathologists and ensures a more standardized diagnosis. However, AI is not infallible for clinical image analysis. It can lead to errors and biases, which we have discussed in prerequisite learning units. For example, AI performance can be limited by the data it was trained on. If a tool was only trained on a specific population, it may exhibit bias when applied to others. Moreover, in medicine, a model trained on a population where females are consistently overdiagnosed for heart disease may lead this bias to continue underdiagnosed females when deployed in a new clinical setting. Next, while AI is excellent at pattern recognition, it lacks clinical reasoning and holistic patient view that you possess. This means AI in clinical image analysis lacks the human ability to integrate findings with patients' broader clinical history. And lastly, there's over reliance on AI, also called as automation bias. This can lead you to ignore your own clinical judgment. Students show that when AI is biased, clinician performance tanks, dropping well below their baseline. Therefore, always ask, is this AI output consistent with the patient history and physical exam? Some of the most dangerous errors are not obvious failures, but hidden ones. Bias is often invisible during normal use. It only becomes apparent when the model fails. Now let's move to hidden pitfalls. AI is prone to shortcuts. In computer science, a shortcut occurs when a model relies on irrelevant data. Research led by Dr. Jana Vince illustrates this. A model might accurately predict heart failure, but only because it learned that patients with pacemakers often have heart failure. If a patient had heart failure without a pacemaker, the model might fail because it didn't learn the underlying features of a heart failure. Think of it like a model trained to recognize cows only in green fields. It might fail to recognize a cow on a beach because it is actually looking for the grass. After knowing all of these hidden pitfalls and biases, you may come to a question: how do we as clinicians mitigate these risks? There are a few steps that you might consider. First of it is independent verification, which means always review the image before looking at the AI output. Secondly, calibrate your trust. Recognize that AI in image analysis is a tool, not an oracle. If the AI output contradicts the clinical history, prioritize your clinical judgment. Thirdly, AI suppression. In the future, systems may use suppression strategies to retract diagnosis when the probability of a misleading event is high. Your goal as a clinician is true interpretability, understanding why the AI is suggesting a diagnosis and ensuring it aligns with the patient's overall clinical picture. And the last step is check confidence. Interpret probability scores critically. High confidence does not guarantee correctness. So now we know that AI in image analysis is a powerful tool, but its value depends on your ability as a clinician to interpret it critically. The future of image analysis is multimodal, combining images with clinical data, genomics, and longitudinal records. As foundation models emerge, the clinician's role will evolve, not replaced by AI, but reshaped into a supervision of complex data driven systems. Your role as a clinician is not to compete with AI, but to supervise it safely. Thank you for watching this video. In the next videos of this learning unit, you will take a closer look at specific examples of AI tools for image analysis in different fields of medicine used by healthcare professionals in the differential diagnosis process.